thanks again for joining us all. So my name is Michael Hanlon. We've got some of our primary care facilitators who are going to be doing the webinar as well. If we just go to the contents, just to give you an idea of what we're going to cover today. So we're going to give a brief introduction about CEG, who we are and what we do and how we can help you guys. We're going to give some updates about kind of QoF updates and LAYS updates for this year, as well as some information about PTN support and our APL tools and how that can help you achieve lasers and outcomes and things like that. Then we're going to talk a little bit about the data quality accreditation incentive scheme, and then, like I say, this longer section for feedback on what we can be doing to help you guys. So if we go on to talk about a little bit about who we are. So we're based at Queen Mary University London in Whitechapel, and we're actually founded by local GPs from Tower Hamlets, and over the years have kind of spread out to support practices across North East London. So what do we do? So we create dashboards with data from primary care across NEL to help practices kind of know where they are with various different indicators. We create system searches and software tools to help you achieve those indicators. We liaise with local interest commissioners about local services as well. Because of the expertise that we have in creating searches and going through things like QoF rules, we identify where there are issues in some of those things, and then we raise those to the national team as well. So trying to help actually make the rules make sense and fix issues where they've arisen, because they're not always perfect. So an example of this was with the IIF indicators last year. There were major issues around familial hypercholesterolemia, and we lobbied to have those changed, and they were then eventually changed. The other thing, that kind of example that springs to mind, is with the cohorting as a service COVID vaccine dashboard. We identified a few overzealous codes that were kind of inappropriately flagging children as being clinically vulnerable when that wasn't the case. We flagged that to the national team, and they're now removing those codes, so we can kind of help flag any issues that have been identified in national searches and things, national indicators like QoF and things like that. We have an absolutely brilliant facilitation team to support all practices in NEL, and that can be kind of with troubleshooting things or explaining how to make best use of our searches and clinical system tools to achieve those local and national targets. And we also have a research arm as well that publishes kind of nationally and internationally and trying to kind of improve clinical outcomes and clinical effectiveness. All right, so should I hand over to you, Toyin, to give us the kind of QoF updates?
Okay, my name's Toyin, and I'm the primary care facilitator for Tower Hamlets. So I'm going to start off with the QoF updates for this year. So one thing to know for this year is that all disease registers are income protected. So your performance on the disease registers will be based on what you got last year. Points remain the same at 635 and are valued per point at £213.43. And this is based on the average list size, which is 9,639. So you have your clinical indicators, which is worth 401 points, your quality improvement, which is worth 74 points, and your public health, which is worth 160 points. So for this year, there are 3 new indicators, and 2 of those new indicators come in a new area, which is the cholesterol control and lipid management. So the first indicator is for patients who are registered on the CHD, PAD, stroke, or CKD register, who currently need to be prescribed a statin. If a statin is unsuitable or they decline, then you'll need to prescribe them another lipid-lowering therapy, and this is worth 14 points. The second indicator is for patients who are on the CHD, PAD, or stroke register, and they need to have a non-HDL cholesterol that is lower than 2.5, or if not a non-HDL cholesterol, then an LDL cholesterol, which is lower than 1.8. And this is worth 16 points. So together, this new area is worth 30 points. So the third new indicator is for mental health. So patients who are on the mental health register need to have a physical health check, and they need to receive all 6 elements of this. So that is blood pressure, BMI, HbA1c and cholesterol blood test, alcohol consumption, and they've included smoking status. So this is now the same as the SMI physical health check DES. So working on this will also help you to reach your DES target. There's also been some changes to existing QOF indicators. So the first one is for the AS008 indicator. So it's for patients who have a CHA2DS2-VASc score of 2 or more. They need to be prescribed a DOAC, or where this is declined or unsuitable, a vitamin K antagonist. So this indicator is actually the same as the IAS CVD5 indicator from last year. For CHD, hypertension, stroke, and diabetes, you can now include home blood pressure readings, but they need to be equivalent home blood pressure readings. So for a BP target of 140/90, you can have an equivalent home BP of 135/85, or where the BP target is 150/90, an equivalent home BP of 145/85. The next indicator that's being changed is for heart failure. So they've updated it to look at diagnoses since the 1st of April 2023. Previously, it was the 1st of April 2021. So these patients require an echocardiogram or specialist assessment confirmed 6 months before entering the register. Originally, it was 3 months before to 6 months after entering the register, but for this year, it's 6 months before entering the register. The next changed indicator is for COPD. So patients who have a MRC, breathlessness scale of 3 or more, need an actual record of a referral to pulmonary rehab. So last year, you could code an offer of pulmonary rehab, but for this year, there has to be an actual record of it. There's been further changes to 2 more indicators. So for rheumatoid arthritis annual reviews, this has been removed, and it was for 5 points. And then for dementia, they've reduced the points from 39 to 14 points. So that's a total reduction of 25 points. So put in the 5 points from rheumatoid arthritis and the reduced 25 points from dementia together, that's 30 points. And that's what actually goes to the 2 new cholesterol indicators. Okay, so we've got QOF childhood immunizations. They have decided for this year to remove the payment clawback for patients for practices, who perform under 80%. So they've removed that payment clawback. And for the 3 immunization indicators, they've reduced the lower threshold. So for VI1, they've reduced it to 89%. For VI2, they've reduced it to 86%. And for VI3, they've reduced it to 81%. And they've raised the upper threshold by 1 percentage point to 96%. There are still no new PCA codes for the immunizations, so your decline codes will still not count towards your target for immunizations. But for this year, the search will exclude children who register too late in age. Are there any questions so far about the QoF updates?
There are no questions in the chat box, but we've got a hand up. Emma Bayliss, did you want to hop on the mic?
Hiya, thanks. Just want to double check with the COPD 014. You're saying about MRC greater than 3, a record of referral to pulmonary rehab. What if a patient declines? Because a lot of our patients do. So we code as offered. But are you suggesting that we should just refer? I just think, what if the patient says, no, I don't want to go?
Okay. I wouldn't suggest that you just record refer unless you do actually refer them.
But are you suggesting that we should refer someone even if they don't want to? I'm not sure how we achieve that is what I've struggled with.
Unfortunately with this one, so if pulmonary rehab's not available in the area or is unsuitable, then both those two codes in the last 12 months will count. But if a patient declines, that doesn't unfortunately include them in the indicator. To be honest, it's quite a small number of points, so I wouldn't get kind of too het up on it. It's quite a large kind of difference between the lower threshold and the upper threshold. But no, if they decline, then no, they shouldn't necessarily be referred. But unfortunately, anyone that is essentially kind of offered pulmonary rehab will be kind of included in the what we call the denominator, but won't necessarily count towards achieving the target unless they actually agree to and are referred.
Okay, fine. So we'll continue with the same practice then. I just just wanted to clarify.
Yeah, absolutely.
We do offer to everyone. But
if someone is unsuitable for pulmonary rehab, it's really important that you code that because they will count.
Okay, so unsuitable. Okay,
so
that's
unsuitable for pulmonary rehab will count, as will if pulmonary rehab is unavailable in your area. But I don't think that's going to be the case necessarily.
No. Okay. Thank you so much.
Any other questions?
Yeah, we've got a question in the chat box from Malgorzata Farrelly. I hope I pronounced that properly. Does pulmonary rehab have to be done yearly or 3 yearly? Either Mike or Toyin, do you want to pick that up?
It doesn't have to be done yearly. It depends on what their MRC score is. So if it's 3 or more, then they do have to be referred to rehab. But if they...
I think it does exclude anyone who's previously attended pulmonary rehab since that score of MRC score of more than 3.
I mean, if you clinically feel that they do need to be referred again, that's fine, but it won't interfere with your target.
Perfect. I hope that's answered the question. We do have one more person with their hand up. Archana from Ruston Street Clinic. Did you want to hop on?
Yes, I just wanted to ask about cholesterol testing. So the way we've got it done is we do all the bloods for Part A. Now, if the indicator is asking us to aim for a target cholesterol, which we haven't done up to this point, does that mean we have to retest the cholesterol after intervention? It just needs a bit more guidance because that now means more blood test.
So for Part A, you'll do a cholesterol blood test for certain patients. I don't think you need to retest them if they hit within the target, which is for non-HDL, it's 2.5, and for LDL cholesterol, it's 1.8. Then that satisfies the indicator. I guess if their cholesterol is higher, then they're
Yeah, just having a
get
quick
these
look at the
indications.
QOF rules. So it's indicating where a non-HDL cholesterol target hasn't been achieved, treatment should be intensified.
Yeah.
So that would suggest that you probably would want to recheck to make sure that their LDL cholesterol has been lowered by the kind of usually by 40%, but making sure that it's kind of in line with the target thresholds.
Right. Okay. Because with on the recent GP update course, they were actually sort of nice. Well, I think it was nice guidance, which said that there is no merit in going up to very high levels of statins, and they were actually talking about just having patients on lower levels of statins. So I'm just really surprised with the QOF thing now. Expecting us.
Yeah, the
Mm.
QOF rules unfortunately don't always align with everything in NICE, and it may well be that we see in subsequent years that kind of trickles down through. Currently, at the moment, is set about those thresholds for the cholesterol. Again, I think that the threshold for that indicator is set at 20 to 35%. So it won't necessarily be every single patient that you have on a statin that you needs to be there, but certainly a good chunk.
Okay. Great. Thank you.
Perfect. We've got one more question in the chat box, and actually Malgorzata has her hand up. Did you want to pop on the mic and ask your question?
Yes, I've got a few questions, sorry. So regarding the vaccinations, it was like, when the child is registered too late, but what is too late? What if they register 2 weeks before the final kind of cutoff is for that particular vaccination, or a week? What is that too late? Or is it that they too late because they already passed that date? Shall I do one question at a time and you answer? That might be easier.
Yes. Yeah. Okay. So for the exclusion of patients, children who register too late in age, so there are different stages to it. So for instance, for the third 6-in-1 vaccination by the time they're 8 months. So if the patient registers at 8 months or more and they have no history of this vaccination, then they'll be excluded. If they register at 7 months, and I believe they have the 2 doses of the 6-in-1, but not the third dose of the 6-in-1, they'll be excluded. So it's that kind of
Yeah, but for example, like let's say register day before day 8 months. So obviously you've
right.
got no chance for doing it, even though they registered not after. So it's still, you can't exclude them.
So it's better than it was last year, but yeah, it's not completely going to exclude every
Thank you.
child.
Sure. Yeah. Okay. And thank you. And with the pulmonary rehab, because the reason I ask whether it's 3 years, because in the past we used to refer every 3 years if they score was 3 or over. But now essentially you're saying that it has to be done every year for the QOF. They would have to have new referral every year, not every 3 years for the pulmonary rehab.
No, not every year. So if you've already previously referred a person to pulmonary rehab, they'll be excluded. So
Okay.
yeah. So these are basically patients who've never been referred to pulmonary rehab.
I see.
Yeah.
Thank you. And for the blood pressures, so for the diabetes, the NICE guidance were changed because before the blood pressure threshold was 140/80, and the guidance was changed to 140/90.
Yeah.
But suddenly last year on QOF, that wasn't the case. It was still on QOF existing as 140/80. So do you know if, as I understand what you were saying, obviously about the home blood pressure and how that is different from the blood pressure done in a surgery, but will the target remain 140/80, or has that been changed to 140/90 for diabetes as per NICE guidance?
I believe it's changed to 140/90, but I would have to double check that for you.
Yeah, just having a quick look at the QOF rules, it looks like it's 140/90.
Right, yeah.
for
It is. Okay.
DM033
Okay.
for diabetes.
Thank you. And you know, the last one regarding the cholesterol when patients need to be put on statin for the cardiovascular disease or stroke and so on, statin or alternative of statin. In the past, I think the alerts were not recognizing, for example, rosuvastatin or the newer kind of, cholesterol reducing medications. Only atorvastatin or simvastatin was kind of recognized as a statin. So will that, which medications essentially will count as a statin prescribed?
So it should really be any statin, or if they're unsuitable for a statin, another lipid-lowering therapy. That might just be something then we need to look at just to see if it's an EMIS-based alert or if it's one of our alerts, and just double check that it's including all statins, because it sounds like it should be.
It should be, but it wasn't suddenly. So so maybe guys,
Yeah, so we
because
can
I'm just
take a look.
sure that it needs to be tweaked somehow, so it's
Yeah,
recognized that we can prescribe other statins. Thank you.
we'll
Thank you so
we'll
much.
take a look at that, and we'll get back to you. All right.
Thank you.
So do we want to carry on then with the Liz section?
Okay. Okay, so the Liz updates for this year. So there's been a slight change to the asthma indicators for integrated care. There's been a change for the surgical aftercare and wound care service, and for the ICCQ enablers. Just a note about the utilization of trigger tools enablers. So a lot of the trigger tools, or all of the trigger tools, have been withdrawn, but there's still discussion with the commissioners about what to do to replace this enabler. So once we have that information, we'll let you know. So I'll talk about the young people's enablers and the digitally excluded. So there's been no changes for the other services for this year. So for asthma, as you probably know, for cough, you need to do a self-management plan, a control test score, the number of exacerbations in the past year, and also include the annual review code. But for the integrated care asthma indicator, you will also need to do an action plan, which you will have to code as the personal care plan completed. For adults only, you will also have to include the wider determinants of inquiry questions as well. So for the asthma indicators, you don't need to do a full care and support planning. So you don't need to do a Part A and Part B. So what you should do instead is have an extended consultation where you do an asthma and inhaler review. You do the wider determinants for adults, and you complete the asthma action plan. So you can use our LTC review template for the codings, and we also have a support search called Asthma Plans and Reviews that will help you with this as well. Okay, so there's been a slight change to the wider determinants of health inquiry part of the integrated care. So to record that you have asked all of the questions or discussed all of the sections with the patient, you need to make sure that you code quality of life assessment completed. So the different sections of wider determinants is communication, literacy, lifestyle, housing, employment and income, and social isolation. Again, please use our LTC review template. There's the wider determinants page on there. We also include the wider determinants page on a lot of our other templates as well. Completing this will also help you achieve the second part of the new data accreditation scheme, which my colleague Shazia will talk to you about later. So moving on to surgical aftercare and wound care. So the surgical aftercare part, there's no changes. So you can still record suture removals, clip removals, and wound care as you usually do. The new part of this is the minor injury wound care, which you should code with consultation for minor injuries. And this is for injuries that don't require secondary care and can be dealt with in practice. So that's things like grazes, minor burns, and skin flaps. Again, please use our template. So that's the surgical aftercare template. Moving on to the enablers. So the young people's enabler, this is to proactively promote access to local GP and health services for young people. And you need to demonstrate that you are proactively updating young people's phone numbers. So you need to implement your plan for the Your Welcomes outcome. And you need to do this before the end of the year. You need to send patients who are turning 14 years of age a letter, and this letter tells them how to access local services, tells them that they can be seen on their own if they want to, and that they have the right to confidentiality. You need to code this with patient in local audit, but this code is attached to the letter. So if you save the letter in the patient's record, it will also put in the code as well. You need to do a promotion of the C card scheme, which is the Come Correct scheme, which provides condoms in outlets across London so patients can register online. And you also have to provide evidence of how you're listening to your young people. So this could be by doing a school survey or putting something on your website or social media if you have it, and you have to show that you are acting on any feedback or findings that you get from your young people. Moving on to the digitally excluded patients. So this is to increase the awareness of patients who are digitally excluded, so patients who don't have a mobile phone number. What practices need to do is they need to review their last year's digital exclusion policy and update it. And this you should have done already because the deadline for it was the 30th of June. You also have to comply with a compliance audit by the end of Q3. So make sure details such as date and time of engagement with patients and staff is recorded. You need to also contact patients who are not LTC patients, as they will be asked this question as part of their long-term conditions review and as part of the wider determinants inquiry. You should code education about access to patient-facing services when you have discussed with a patient who doesn't have a mobile phone different ways in which they can contact their GP services and the different ways that the GP can contact them. And then you'll need to put this on your clinical system so that everyone in the practice knows how the patient wishes to be contacted. So I just want to go over quickly a recap of the services that are the same this year. So we've got latent TB. So what you need to do is code the blood test results that come in to your practice. So the code for that is interferon gamma assay, negative or positive or indeterminate. But as I said before, we have templates to help you with your coding. So if you use the health check template, there's a latent TB screening page on there. And you also have to refer any positive results to a TB clinic. And we also have support searches to help you with this as well. So it's the latent TB screening support search. For NHS health checks, you need to complete NHS health checks. For high-risk patients, you need to do a CVD annual review, and you also need to prescribe them statins. For patients who are aged 65 years or over, you need to record their pulse. And for patients with a Q risk of 10 or more, you need to discuss lifestyle programs, and also you need to record the carer status for any patients who have carers. Again, please use our template, which is the health check template, and there's an NHS health check page for that. For substance misuse, you need to do a health check and health plan for each patient. You need to record the alcohol status, so using Audit C and the full audit, with advice or onward referral where appropriate. Patients who are prescribed methadone or antipsychotic medication also need an annual ECG. You can use the substance misuse and alcohol template, and we have support searches for this as well. So substance misuse, NIS support. For sexual health and LARC, you need to complete STI screening, and this is for new registrants and high risk or vulnerable patients. You need to do STI diagnosis with partner notification and referral or follow-up. For patients needing hepatitis B, you need to complete their vaccination course and also do post-vax testing. And for LARC, you need to do coil and implants, insertions or removals. But I would also like to remind you, if there are any unsuccessful insertions or removals, please record this as well, because you will get paid the same as if you did actually do a successful insertion or removal. For inter-practice referrals, you get paid £10, and for any inter-practice VNAs, you will get paid £25. So we have a template for this as well, which is the Women's Health template, and there are also support searches to help you as well. So here are some of our support searches, and I'm just going to give you a quick demonstration, if you just bear with me, of where to find our support searches. Okay, so what you'll need to do is you'll need to go to the clinical effectiveness group domain, which you will find here at the bottom, filters. If you don't see it, if you click on this little arrow here and go to add or remove buttons, you'll be able to see the CEG domain. Once you're in our domain, if you navigate to the Tower Hamlets Practice Support 2023/24, folder, you'll see all of our different folders where we have support searches for you. So for integrated care contracts, we have ADHD annual review searches, asthma plan and review searches, and also searches for the 2 enablers, young people and digitally excluded. We also have public health support searches. So we've got latent TB, NHS health checks, and sexual health support searches for you. And we have a set of PCN contract searches, so care home, IIS, and SMI physical health check. So if you haven't already, what you need to do is to go back into your practice domain, create a folder, and then copy our support searches over to your practice domain where you'll be able to run them. I would suggest that you do it folder by folder if you haven't already. And then please look out for our updates in our e-bulletin to find out whenever we've made updates to the support searches, and then you would come back into the clinical effectiveness domain, copy the updated search and paste it into your domain and your folder. Okay, so just go back. So, any questions?
So I think we are okay. We did have a couple of questions in the chat box, but I believe
Okay.
we've already answered them.
Okay.
So unless anybody wants to put their hand up and come on mic now, I think you're okay to go on. That's okay. You can go on.
All right. So I'm just going to hand you over to my colleague Faye, and she'll talk to you about PCN network support.
Thank you, Tyan. Hi everyone, I'm Faye Wilkins, Senior Primary Care Facilitator at the CEG, and I cover Tower Hamlets and Waltham Forest. So I'm just going to give a brief overview of the PCN network DES support that is out there, whether it's provided from us or from the NEL-BI team. So in regards to the 2-week access, you can use the PCN dashboard, which has the GPAD data in as well. The early cancer diagnosis, this is part of our IIF dashboard, which you can find on our website. The dashboard for measurable DES targets, we are going to be updating our IIF dashboard to include this area. And then the CVD metrics, which are from last year, we are going to suggest you use the NEL outcomes framework as this already exists. And we also have prevalence improvement searches for case finding, and they are within the support folder that Toyin just showed you previously. For the social prescribing metrics, NEL-BI team have already created a social prescribing dashboard, and on the next slide there is just an overview of what that dashboard currently looks like. But you do need to request access to the NEL-BI dashboards. The structured medication reviews, this is now included into our IIF dashboard as well. The enhanced health in care homes. We do some of this, so we have got support searches within the PCN folder, but we do not do the ward rounds. So you would need the appointment book, and it could be in the PCN dashboard as well. How many beds in the care homes? You would need to get this from the ICB, or you'd get it from the care home directly. And then the ethnicity indicator, again, this is within our IIF dashboard. Next slide, Toyin. Okay, so this is just a quick overview of what the social prescribing dashboard looks like. I'm not going to go into any detail on this, but it would be good just to try and get access to it, just to give you an idea as to how many patients are being referred into social prescribing, and for what was the reason behind the referral, whether it was a housing problem, financial, social isolation, etc. Is there any questions around this? Maggie, yes, the slides will be emailed out to everyone after the webinar.
Okay, we've got one hand up. Archana, again, if you want to hop on the mic.
Yeah, I just wanted to know, is it possible to send the link for accessing the dashboards, please? I'm not sure exactly where to find them.
The nil BI ones, yes, we can provide the links for you.
Thank you.
And Rachel, hopefully that's answered your question as well. If there are no more questions, I think we're okay to go on.
Okay, so we're going to hand over to Karishma, and she's going to talk about our APL tools.
Good afternoon, everyone. My name is Krishma, and I'm a clinical facilitator at CEG. In this section of the webinar, I'm going to brief you on the tools that we have for you that are currently available to use for the different services that you have. So on your screen, you've got 4 different descriptions of the 4 tools that we've got at the moment. The first one would be the Cancer Diagnosis Audit Tool. And the purpose of this tool would be to help you review your practice's processes around suspected cancer referrals that lead on to confirmed diagnoses. So in short, to audit your recently diagnosed cancer patients. The second one would be the National Diabetes Prevention Program tool. And the purpose of this tool is to easily identify which patients of yours are eligible for referral onto the program, which ones have been referred and which ones are yet to be referred. The third tool is the renal tool. It was previously known as the falling EGFR tool, and the purpose of this particular tool is for you to be able to manage your patients with CKD, chronic kidney disease, better. The fourth one is the Child EMS call and recall tool that's been around for a long time now. The purpose of this tool is for you to be able to see the children registered within your practice with incomplete or overdue sets of immunizations and help in better call and recall. Next slide, please. So as I said, I'm not going to go into great detail. We've got webinars for each of these tools, extensive in detailing the use and how it works in details. At the end of this webinar, we're going to provide you with links for the previous webinar recordings and also for the request forms. I'm just going to brief you around how these tools work. So first, the Cancer Diagnosis Audit tool is there for you to it's there to assist you in the service requirement for early cancer diagnosis, which is in your PCN-DES. It's a reflective tool. It's not for you to manage. It's not to be used for how you manage your cancer patients. So how it works is basically you'll have a search that will be accompanied with this tool. You would run the search to get the list of patients that would be eligible for this audit. And as I said, it would be your newly diagnosed cancer patients. You would then import those patients onto the tool, and you would then be able to audit each of the patient row and enter information. Once you've done that, you can then look at those patients as a group and look at areas where you might need to improve when it comes to your referral processes, and then hopefully implement changes that you would have discussed and agreed upon, and then you repeat this whole process again in the following quarters. Next slide, please. So this is just a brief overview of what the tool looks like. Hopefully you've seen this before when you've attended the webinars. The columns in blue, please bear in mind, are not editable. So the reason why they are in blue, it's because it will automatically pull this information from your search into your tool. So you do not have to input anything, it will auto-populate these informations for you. So that be patient's EMIS number, full name, date of birth, gender, deprivation quintile, ethnicity. And we've also got information, you'd also be able to see whether your patient is on either the housebound, dementia, or SMI registers. The columns in white headers are the parts where you need to fill in when you're carrying your audit. So that would include things like at which stage was your patient diagnosed at, which tumor group that particular diagnosis belongs to, whether your patient had any communication needs, where your patient presented first, was it at the GP or in A&E, what tests were requested and organized for that particular patient, and how many times they had to attend the practice before they were referred, and what was their main presenting symptoms. So these would be the bits and bobs that you'll fill in for each of the patient. These information are in line with the more detailed information that surrounds the service requirement. So it's in line with what you're expected to carry out. You do not have to submit this anywhere. It's just for you to be able to show that you've actually done what you've done around that service requirement if asked. Next slide, please. The National Diabetes Prevention Program tool helps with the Healthier You NHS Diabetes Prevention Program that's out there by NHS England. This particular tool is a patient referral management tool, and it's for patients over the age of 18 with pre-diabetic sets of results. Again, how it works, you'd have a search that will pull all your eligible patients, and these patients should have a recent HbA1c or fasting blood glucose above normal, but not in the diabetic range. And when you've pulled this data, when you import the data into the tool, you'd be able to see whether they've been referred onto the program or not, and then you can decide on how to action the patient. So you might choose to refer patient individually, or you might even choose to action it in bulk by maybe sending bulk text messages to these patients. And you can do so by exporting the list to AccuRx. And again, you would then repeat the whole process at regular intervals according to your practice's needs. Next slide, please. This is how the tool looks like when you request for it. So on the left side of your screen, it's the main page that you'll see once you've imported your list of patients. You'll have a whole list of patients, but then you can choose to filter them according to your requirements. So you can choose to filter the patients by those who have been referred, those who haven't been referred, and those who have been declined. You can also choose to filter them by age, so under the age of 65 or over the age of 65. You can choose to filter the patients by the ethnic group, and that could be because you've got certain reading materials in certain languages or stuff like that to so you want to see which patients are of which ethnic group. You can also filter them by their BMI or by their other comorbidities, so whether the patient's got CVD or hypertension. On the right hand side of your screen is basically for each patient, you can see individual patient data. So you can click on a particular patient and you'll be able to see more information around that patient, so including their risk factors, but also you'd be able to see that it also pulls information around their contact details, and that the benefit of that it's you don't have to go back into the patient record if you need to contact the patient to offer them a referral. Next slide, please. The CEG renal tool was revamped and recently release. We only hosted the webinar for this particular tool about a couple of weeks ago. So hopefully you all attended to that. So quick reminder, the way it works, it pulls all your patients with abnormal ACR or EGFR readings. Some of these patients would be on your CKD register. Some of them might not be on your CKD register. So you'd be able to see those with outstanding actions. You can then choose on what action you would take. So you might choose to refer onwards, you might choose to carry out a medication review, you might choose to refer for blood tests. And again, as with our other tool, you can also export the list onto AccuRx if you do want to action in bulk. By using this tool, we hope that you'd be able to improve on your CKD coding. Next slide, please. So if you've not seen the tool before, it looks like this, as you can see on your screen. So again, on the left-hand side of your screen, you've got the main page. Once you've pulled your total list of your patient list, and again, you've got filters that we've put in for you there, so you can look at patients by how much their EGFRs fallen. So you could look at patients with a fall of more than 10 or more than 15. You can also filter by those who've not had a repeat EGFR recently. You can also filter by blood pressure readings, so those with a blood pressure reading of less than 140/90, those with blood pressure more than 160/100, or those in between. You can also filter by patients on certain drugs, such as those on the SGLT2, on the ACE inhibitors or ARBs, and on statin. You can also filter by comorbidities such as CVD, diabetes, hypertension, heart failure, and AF. On the right-hand side, again, you have got a individual patient data page, so patients' basic information as well as their recent trend around the EGFR value. So it's almost like a virtual review page for that particular patient. Next slide, please. Last but hopefully not the least of the tools that we'll have available for you is the child immunization call and recall tool. This particular tool will help you work on your vaccination and immunization squaff, as well as help you comply with the UK childhood immunization schedule. As it's in the name, it helps with childhood vaccination recall management. Again, how does it work? You've got an accompanying search that will pull your list of patients aged 0 to 5 years, and then when you import that list of patients, you'd be able to see those with incomplete set of immunizations. You can then filter by those who are due for the vaccination, or those who are overdue. You can also see contraindications and declines on individual patient page. And again, like with the previous tool, you can export onto AccuRx or OneContact. Next slide, please. If you've not seen the tool before, that's what it looks like. Similar format to our tools that I've shown you already. So the APL child immunization tool has a main page where you can filter by age band once you've imported your list of patients. So you can look at those who are younger than 8 weeks, 8 weeks, 12 weeks, 16 weeks, a year, or 3 years and above. You can also look at those whose vaccination status is due in the forthcoming week, or those that are overdue. You can also filter by certain vaccinations like the rotavirus, the PCVs, the MMR. I know as I know that in practice sometimes you may have a stock surplus of vaccinations, and I think this particular feature in this tool helps because you may have a surplus of a certain vaccine that you might want to use before it goes wasted. And by using this tool and filtering by that particular vaccination, you can easily identify which patients are due for that particular vaccine. And again, if you want to look at your new registrations, you can also filter by those who've recently registered within your practice within the last 2 weeks or the last 4 weeks. As mentioned, you've again got individual patient data page where you can see the basic information around that patient, but also see a comprehensive list of immunization for that patient. And this is the page where you'll also be able to see whether there was any previous contraindication or declines for your patient that is in question. Next slide, please. So how do you access these tools? We've got request form for each of them, and you might think, oh, why do I have to do that? The reason is so that we are able to have a list of those who've requested for our tools, because should we need to contact you about anything, if there's any update or any information that we need to pass on to you urgently, then we can share that with you by looking at the list of people who've downloaded the tool. So these are the hyperlinks. As we've mentioned, we will be circulating the slides to you. You can just click on each of the hyperlinks to request for the tool that you'd like to use. Next slide, please. That will be it. As I mentioned, this is just a brief description, and I would strongly encourage that you click on the link for where you can access the previous webinar recordings for each of these tools, and there will be much more details about these individual tools. Thank you.
Right, so it doesn't look like we've got any questions in the chat. Did anybody want to pop on the mic and ask any questions? Okay, I think we're done. On to the next section. And that's me. Hi everyone, my name is Shazia Shazad. I'm a primary care facilitator covering the City and Hackney Borough. It's my name on this slide, but I'm the co-project manager from the CEG end for this, working alongside Faye Wilkins, also on the call, Keith Prescott, CEG manager, also on the call, and Dr. Tom Margam from the Equip team, who has just wonderfully dropped off the call. So I'm just going to give you a high-level review of the Data Accreditation Improvement Incentive Scheme, that lovely acronym right there. And I'm going to be detail light on this, reason being we've got a webinar coming up to cover everything about this imminently next Wednesday, but I'll talk more about that at the end. If we can go on to the next slide, please. So what is the Data Accreditation Scheme and why are we doing it? So this scheme is a joint effort between us at the CEG and now ICB. And what we're doing is we're trying to support you with capturing good quality data, and we're focusing on 2 areas. We're focusing on the wide determinants of health and consultation types and job roles. Next slide, please. So why are we looking at the wide determinants of health? Well, you've got a LIS dedicated to this already, but it's already known that healthcare inequalities are interlinked with the wider determinants of health. So what we're trying to do is improve the data capture, which allow you to identify the patients who are most at risk of poor health outcomes and suffering from inequality of access. And then you can use this information to facilitate the development of targeted support and interventions for those you identify being at need. Next slide, please. The other side of this, the consultation types and the job roles, why are we focusing on this? All the pressures on general practice higher than ever before, and it's imperative that you are working with whatever resource you've got, you're working smarter, and that you are, by doing so, still able to provide good quality care in a safe manner. We cover the whole of NEL, and between every practice, it's over 200 practices. Every practice has its own way of recording consultation types and job roles, and this therefore means that you cannot really look at this data and draw meaningful conclusions from it. On to the next slide. So by complying with this incentive scheme, this will help you in the practice to understand your own activity and workload, and it will help you to capture some elements of unplanned care. So within the scheme, we promote the use of the Apex tool, and we promote another NEL dashboard, which is the Care Encounters dashboard. Both of these platforms will pull your consultation type activity, it will pull your staff roles, and then it will present that to you in a way where you can see, right, this staff is doing this amount of work, this staff group is seeing patients for this amount of time. Essentially what it's doing is it's clarifying that, and then you can look at that as a practice and say, I know who is doing what. But also, as we'll have all practices across now, all the practices who have signed up working in the same way, we can then look at that data on a NEL perspective, and it will help to inform the understanding of demand and pressures across the patch, and it will help you to identify locally and for NEL to identify any areas where extra resource might be needed. Just wanted to mention on there that you've got the capturing some elements of unplanned care, and I'll just give you a little example here of what that might mean. You've got GPAD data, capturing your data from your appointment book, and say if you're a GP, you get a result sent to you that needs a discussion, an urgent discussion with a patient. Are you going to diligently put that telephone call at the end of the day into your appointment book so that activity is recognised, or are you just going to get on the phone and call that patient? So this is the beauty of this scheme, essentially, because you're looking at the actual encounters in the GP record, it will help you to see exactly what is going on in terms of what you're entering rather than focusing on the appointment book. So it gives you another aspect of data to look at. On to the next slide, please. So like I said, this is a very, very brief overview, but there's so much behind this little phrase here of tell your own story. And again, I'm going to talk about the GPAD data. We all know what happened at the end of last year when that GPAD data came out. There was national scrutiny. You know, practices were being looked at in greater detail. Patients were saying, you know, the access level here is pretty poor. It was in a percentage. So essentially what we're doing is we're putting the informatics back in your hand. Once you've put that into translatable data, you can then look on Apex, you can look at the dashboard, and you can build your own story and say, right, whilst GPAD data is saying this, we can tell you from our own record that we are doing this amount of work. So it helps you in that way. Next slide, please. So I mentioned earlier that we've got a webinar focused purely on the launch of this spec. So that is next Wednesday, the 19th, and it's from 1:30 to 3. There is a link to book in the bulletin that went out last week, and it will again be in the bulletin this week. And what we'll do is we'll run through the spec with you in greater detail, as well as outline the support package that we have made available to you. I will just say, I think we've had an over 80% sign-up rate from Tower Hamlets, and just looking through this today and looking at the slides that my colleague Toyin has put up, you've already got a Liz around the wider determinants of health, and you are doing 80 to 90% of the work already. So if you haven't signed up, it's worth having a conversation with us just to sign up, or just to explore the idea of a late sign up, because essentially you're doing all the work, you should get paid for it. And there is no penalty attached to this as well. I just wanted to emphasize this is a spec whereby if you comply with the phases, then you'll get paid with as much work as you do. It's not one of those contracts where at the end of the year you'll be running around trying to tick boxes. So you'll get paid as much as you do. There's no pressure on this one. Okay, on to the next slide, please. Any questions? I haven't seen any in the chat box. And unless, oh, yes, we've got a hand up. Sangeeta, if you want to go ahead.
Thank you. I suppose you'd tell us more at the webinar next week, but I'm still a bit confused about this data accreditation, how it's different from the information we get on Apex Edenbridge.
So we're, like I said, we're promoting the use of Apex Edenbridge, but it sounds like if you're already using it, what you have done at your practice level is you've already clarified your job roles and you've clarified your encounter types, your appointments, and that is in a format that's readable to you. But like I said, we've got all of the practices across now. They work in different ways, and what this is the beginning of some building blocks to having everybody working in the same way. So in that, to that end, once everybody is working in the same way, using the same job roles, they're using the same encounter types, you can then look at that information on a broader level. And like I said, you can use that to plan interventions, to access and identify your not marginalized, but those patients that are suffering from inequalities of access. So it's really building on what's there in Apex. And like I said, it sounds like your practice is already on top of using what's in there. But what we're doing essentially is we're asking that that all practices work to the same standard. And basically you get paid for doing the work that it sounds like you're already doing.
Well, we're not, but I mean, we generally find Apex quite busy and difficult to manage. So it'll be nice if you've managed to simplify it and have some useful data that the practices can look at. But yeah, I suppose we'll probably know more in the webinar next week.
Yes, so hopefully that's the aim as well. But I will just say there were recently put in the bulletin some sessions around using Apex because, like you, when I was in practice and we were given this all singing, all dancing tool, I was like, this is fantastic, this is amazing, this is so complex. But actually, they have been doing some really good webinars that help you to actually read what's coming through there. And I'm in talks with the team really to see whether we can host another one of those once you've got a clearer picture of what this spec is asking of you. To help support again, because I know that Apex has been out for some practices for a couple of years. So we'll just aim for a refresher course to make whatever comes out at the other side a bit more readable for you all. Okay. Any other questions? No. Right. Is it possible to get the link to join the webinar next week? Absolutely. What I'll do is I'll pop it in the chat once I'm off the mic. And brilliant. If that's no more questions, then it's back to you, Toyin.
Toyin, if you're talking, you may be on mute.
Yes, she was. Technical difficulties. Just bear with us a second.
I'm so sorry about that, guys. Just bear with me. I'm going to go down to the slide that I was on before. Okay, sorry about that. As I said, we offer support searches, templates and protocols, documents and APL tools. And I've popped my email address at the bottom of the slide. So if you have any issues or queries about these, please drop me an email. We also offer a weekly e-bulletin where we give you updates about any searches or templates or documents that we've changed. We tell you about upcoming workshops and webinars or new software tools. And we also give key information and announcements. We do weekly, monthly and quarterly dashboards for your LIVs and also your DESIVs. And we do practice visits in person or virtual. So this could be making sure that you are using our most up-to-date templates and searches, or to set up and demonstrate using our software tools, or we do visits to support you with your performance and delivery of your services. So what can the CEG do for you? We'd really like to hear what we can do for you. It could be about searches, protocols, templates, dashboards, practice visits, or our software tools. So I'm going to give it over to you guys for you to tell us what you would like from us.
So if people would rather do that verbally, then put your hand up, and then you can kind of feedback verbally. If you'd like to just pop something in the chat, then feel free to pop a message there in the chat. We're really keen to hear what you guys want us to be doing to help and support you. So like Toyin was saying, whether that be with specific searches or templates, or you've kind of gone, this is a common problem, and if this existed, then this could be really helpful, or we'd appreciate some support from a facilitator about X or Y or Z, then that would be great. Oh, I think we've got a hand up. I can't see whose hand it is though, but fire away.
I think it was Sangeeta again. Yeah.
Hi. I mean, yeah, you always have lots and lots of tools and support things, which is really, really helpful. Just a few things I had was the dashboard. How often does it run? So how live is it? And whether it's possible to make it kind of really interactive and live. Because I think in the past it's about a month behind. So that's one of the questions. One of the other questions is around, you used to have the cytology screening searches for sort of vulnerable groups, last year. Are they still available for sort of, patients with SMI, learning difficulties? Are they still available on the dashboard? And the third question, that's the one, was the cancer safety netting template. It's compared to the national one, it's missing a few things, which it'll be quite nice to add on from the national one. So when we do the 2-week referrals, and code them, it'll be nice to look at. There used to be a few more prompts in the national one, which was slightly helpful. So I don't know whether that can be adapted. That's it.
Okay. Yes, we can certainly look at adapting that for the cancer safety netting tools. Your first question about the dashboards, depending on what service it is, it might be monthly or quarterly when it comes out. We do try to get the dashboards out as early as possible. So I think it's usually by a couple of weeks into the month that we get the dashboards out. We could certainly try and tie up that time if practices are wanting the data quickly. And sorry, your second question was?
It was around the SMI, the vulnerable risk for cancer screening, that is still provided. The dashboard is on our NEL page of the dashboard, the cancer screening uptake, and there are still support searches for this service as well.
Okay.
Just coming in with regards to your first question about dashboards and things, I think it'd be quite useful to find, and we might want to do this offline, kind of which ones you feel are kind of you would benefit from getting more frequently, because we can have a look. There may be some overlapping searches that would cover those patients, so you're able to run that then much more frequently on a live basis, and it may kind of fulfill what you're looking for, rather than needing that specific template. So do you just get in touch with them, with Toyin or the facilitation team, just about which specific ones kind of you're having issues with, or would want to see a bit more frequently.
Okay. Yeah, I will. Thank you.
And then similarly with the cancer template you were saying as well, it'd be good to just get your feedback on which parts kind of you feel kind of would be great to add, and then we can certainly have a look at that. Yeah.
Thank you.
Brilliant. There are a few comments in the chat box which are being answered as we go along. Somebody said there are so many tools, it's quite overwhelming. Agreed. But that's what Toyin is there for, to help you go through them in your own time. So if you pop her an email, she can arrange to visit you, and to help talk you through how to use those tools. How do I sign up to the bulletin? I think we can pick up, if your email address is available, we can add you directly. If not, send Toyin an email to be able to sign up. And yeah, I think that's it. Are there any other questions, or is there anything, in the absence of feedback, I always say, you know, are we doing really well? Is this something people aren't telling us?
Yeah, I've put searches, protocols, dashboards up on the slide, but if there is anything else you want to tell us about, please do.
Like I said, it looks like we're doing well.
Okay.
Is everybody here, just out of general curiosity, is everybody here familiar with our searches, templates, protocols, where to find them, how to use them? Are you comfortable? Are you confident to use them? Or do you think there are any areas that could be improved on? And whilst people think about that, there's another question. Thank you, or not question. Thank you. The tools are very helpful. It would be helpful to have had these in April. To have these in April next year. Is that what you mean?
Yeah, just so that because we've sort of missed 3.5 months worth of work, I think. So it'd be helpful to get these at the sort of earlier in April rather than in the summer, if that's possible.
You are so right. Toyin, did you want to say anything on that?
I appreciate it takes time to go through all the details of QoF, though. I appreciate it takes a long time to edit the searches and to test them and to run them.
I think the other thing with QoF is actually the business rules are kind of constantly getting updated and things like that. So actually that's something that we look through when we see them come out, and we kind of spot things in and we raise them to the national team, and then they eventually get updated. So it can be a little bit of a shifting landscape, particularly around kind of QoF searches and things like that. But yeah, you're right, absolutely. As early as we can get that out in the air is helpful for practice. As a GP myself, I feel exactly the same. With regards to things like the APL tools, we're constantly trying to kind of think about new tools and update the current tools to make sure that they're both kind of clinically safe, but also that they're kind of feature rich and doing the right things. So if you guys have any particular ideas about, oh, I wish there was a tool to help me with this or that, we'd be really interested to hear in that, and we can then have a think about what we can do to make that a reality to help you guys out.
And just to say, I think you're right. And for the APL tools, it might be an idea that what I could do is maybe give a overview of the tools that we have at the beginning of every QoF year, just a reminder, and just to let practices know what we have out there right at the beginning. So yes, that's a good idea.
Archana, said, would be nice to get a short guide on everything you have created. We do have some guides available. Again, Toyin is your best source of information. But I'm just going to take a quick second to signpost you to our new and improved website. And if you follow that link, then you will see that we've got an area called support for GP practices. So as and when we create things that will be useful for you, we'll be looking to upload them there. So if you have any questions or requests, send them to Toyin. We can look to build on that and upload that to our website.
And absolutely email Toyin to get signed up to the bulletin if you're not already as well, because once new things get added or things change, that's one of the ways that we kind of communicate that out. So if you're receiving those, then you're likely to hear about things much quicker.
Okay, if there's no further questions, just got a couple of more slides left. So these are links on how to access our CEG resources. So as Shazia mentioned, the website. And if you want more information about our CEG tools as well, and a link to our dashboards page. Now, this is a hidden page on our website, so you'll need the login details for this. So if you just want to drop me an email, I will send you the login details. And lastly, I just want to promote the fact that the CEG will be at the EMIS conference this year, and it's going to be hosted in London at the Tottenham Hotspur Stadium between the 13th and the 15th of September. So we will be presenting the data accreditation scheme, improving SMI health check targets, the APL tools, the asylum and refugee scheme, and much more. So if you are going to the conference, please see us there as well. And thank you for your time.